I was fortunate enough several years ago to serve Tulare County Office of Education and the Division of Behavioral Health Services with Ron Pekarik, board certified behavior analyst, to consult with a variety of mental health professionals that were providing therapy services to students who have an IEP and have various behavioral problems. Again, we consulted on a wide variety of problems, but we were referred several cases of selective mutism by these individuals. And as a result, we developed a treatment model that relied on the itinerant person, whether it be a mental health professional. We never consulted with speech pathologists, but it would certainly be apropos for them as well, to develop this model in regards to starting with the therapy session, obtaining results, and then transferring or generalizing such results to the classroom. I'm doing this narration because the model actually worked quite well on the few cases that we did consult with, and this narration will delineate those three phases of behavioral intervention treatment for children who have selective mutism in the schools. For those of you that are viewing this narration as a result of the assignment in Chapter 4 of my book, Functional Behavioral Assessment, Diagnosis, and Treatment, with Kevin Schock as the author, the pre-MAC contingency procedures are delineated in Chapter 4. So you should be familiar with those. If you are not using this book and are just viewing this, you might consult Chapter 4 on the detail of the procedures for using the pre-MAC contingency. If you've not heard of that before, that would be obviously a good idea. Okay. Before we begin the three-phase treatment program that I've developed with Ron Pekarik, I want to make sure that when you get a referral for this, and I think speech pathologists would probably be more sensitive to this, but make sure that you are determining that the speech is in fact selective, as in selective mutism, and not the result of a skills deficit or medical issue. In other words, if the child isn't speaking in the classroom, make sure that you have solid, valid data that shows that the child is capable of talking, vocally communicating in other environments. So that's important because this treatment is for selective mutism. If it's a more generalized language deficit, then there would be other behavioral treatment programs that focus on skill acquisition that would be relevant. This is a three-phase program that Ron and I have developed, and it's akin to going in through the back door, and you'll see how that is accomplished. But in other words, instead of attacking vocal behavior directly through some intervention, prompting, etc., we're going to go to a behavior that is more probable with these children. All right, so in phase 1, we're going to target instructional control via task compliance. So we're not going to deal with vocal behavior at this point, but rather gain control of compliance of non-vocal tasks. And we use a pre-MAC contingency. In other words, the child's completion of the designated amount or number of tasks results in the reinforcer. So for example, in one of our cases, we had a child who was capable of writing his numbers, and we simply had him write the numbers 1 through 10 several times as the task. And when he completed that, then the reinforcer was delivered. Now, the goal of this is to increase the number of tasks that occur prior to the delivery of the reinforcer. So in other words, you start small, for example, one task that may take 30 seconds to a minute, and then the reinforcer is delivered contingent upon the child's compliance with that task. And then you start adding more tasks. And you can use a schedule activity board or icon system or anything that lets the child know that when they finish task A, B, and C, for example, the reinforcer is delivered. So over time, what you're going to do is increase from, say, one task to 5 or 6 tasks in order to earn the reinforcer. In other words, the child will be working from, in the beginning, maybe 30 seconds, a minute, 2 minutes, to maybe 15, 20 minutes. So you're getting more work for the same reinforcer. We call it thinning the schedule, and FR stands for fixed ratio. So you start with a fixed ratio of 1 task, and then you go up to 5 or 6, which would be a fixed ratio of 5 or 6. You might ask at this point, why are you concerned with non-vocal behavior when the referral is for the child who doesn't use vocal communication? This program, through phase 1, allows the reinforcer to establish control over behavior in general. And by starting with non-vocal behavior, which is more probable, we can assert that contingency. In other words, the child and the therapist develops instructional control over the child's behavior, so that when the time comes in this program to shift from non-vocal to vocal, the reinforcer that the child earns will take over. It will allow that influence to exert itself so that the child shifts from non-vocal to vocal. And I think you'll see this in the next set of slides material, that how this is done. In session 1, therefore, it's imperative, in order to implement the pre-MAC contingency, that is, when you finish your tasks, you get the desired event. And so in session 1, it's necessary to identify what the reinforcer or the menu of reinforcers is. For behavior analysts, they use something called a stimulus preference assessment, and that material is noted in the literature. Or you can have data that collects observationally, noting when the child is able to do a number of activities, what does he prefer, what does he choose? So it might be wise to have a menu so that the child knows that when they finish, say, 4 tasks in an FR4, that then the access to the menu and the child's ability to select what the reinforcer is for that particular time. Also, I want to mention that in our first case, actually, the reinforcer for completion of the tasks wasn't any activity per se other than escape from the session. I found this out when I talked to the mental health therapist who was working with this first client or child we had that had selective mutism. I said, well, what do you do during the whole session? Well, we sit there and kind of look at each other. Okay. And what happens once the session is finished, where you tell them, okay, it's time to go back to the classroom? And she said, well, he darts out of there like a bullet and heads back to the classroom. So I thought, okay, well, looks like being in the session is not something that he's terribly thrilled about. So we can make that a less aversive event by allowing him to escape much quicker. And the sessions were typically 45 minutes or whatever they were. I think it was that kind of thing. So again, in phase 1, in fact, your first assignment is to actually determine what the contingency will be for task completion. All right, so in phase 2, we're going to do something different, in the sense that we're going to have 2 ways to get the reinforcer. So when task completion has developed to a chain of tasks of about 6 or 7, and you can judge this depending on the child's age, etc., the developmental level. In other words, 20 to 30 minutes worth of work. In other words, the child is going to work for some period of time. You're going to use what we call a concurrent schedule. That's a fancy word for having 2 different ways that the reinforcer can be produced. In the first, you can stay with the lengthy task completion. So if the child simply continues to be non-vocal in the session, they would just work for 20 or 30 minutes or whatever it is, and then receive the reinforcer. But the second way of getting the reinforcer is through vocal responding. So you simply give this as an option. And so it's called a concurrent. It's at the same time, two different schedules for two different behaviors. If you want to go the non-vocal route, it's going to take you a while. But if you just emit any vocal response, that produces immediately the reinforcer. So you can see that what this phase 2 does is it stacks the deck heavily in favor of vocal responding. Okay, so vocal behavior, the reinforcer is delivered for that in phase 2 immediately. And in the beginning, you can have either a one word, any word, with the child I was just telling you about. We didn't make it any specific requirement. If he said anything, he would get out. Man model is a phrase that asks for the reinforcer. So if the child said, "Well, can I have the play activity now?" that would produce it immediately, as opposed to having to work for X number of tasks, or several words. All right, phase 2 is completed when speech becomes prevalent within the therapy session. At this point, the therapist has instructional control over the student's vocal responding, and we're ready to proceed to phase 3. In phase 3, we're now going to be concerned with generalization. In other words, now that we have vocal behavior occurring to somebody in the school setting, we're going to use that to get generalization back to the classroom. So in other words, we're going to transport this program back to the classroom. And the 2 steps I recommend in the beginning are, first, the therapist who has instructional control should spend time in the classroom pairing him or herself with the teacher. Also, teach the staff to set up a reinforcement of vocal behavior in a concurrent manner, similar to what we had in the session. In other words, non-vocal behavior produces one small part of a reinforcer. Vocal behavior produces a large reinforcer. So I think speech pathologists would be familiar with what's called the man model kind of approach. Once that's going, you can have a daily goal where the amount of vocal behavior is set at a criterion, and if that occurs, then the reinforcer is produced at the end of the day. All right, let's talk about how to collect some progress data. Hopefully most clinicians that work with this population are using some kind of pre and post measure of observation, 10 to 20 minutes in the classroom, maybe several times during the pre and then post treatment. In the next set of slides, I'm going to go over a progress evaluation system I've come up with, and that'll be detailed in a second. And then finally, the teacher might construct a series of questions for pre and post in terms of what the teacher has asked the child in a standardized format, again, before treatment and after treatment. All right, here's my rating system for monitoring progress with regards to the 3-phase treatment program. And you can see a number of statements. And what you're going to do is rate them on a scale from 1 to 3, both in terms of a baseline measure, which is in the first column, identified by B, and then a treatment 1 measurement and a treatment 2 measurement.